بسم الله الرحمن الرحيم. My name is الغني الشامي, Professor of Surgery at Ain Shams University. This lecture is about pancreatic adenocarcinoma. About 95% of pancreatic tumors develop in the exocrine tissue of the pancreas. Pancreatic tumors are divided into two main groups, the exocrine tumors and the pancreatic endocrine tumors. This is the WHO histologic classification of tumors of the exocrine pancreas, epithelial tumors and non-epithelial tumors and secondary tumors. The epithelial tumors are divided into benign tumors and borderline tumor and malignant tumors. Here we can see the benign tumors like serous cystadenoma, mucinous cystadenoma, intraductal papillary mucinous neoplasm, the borderline tumor mucinous cystic neoplasm, and intraductal papillary mucinous neoplasm with dysplasia, and solid pseudopapillary tumor. The malignant tumors, the commonest malignant tumor is the ductal adenocarcinoma, with its variants here. The mucinous non-cystic carcinoma, signet ring cell carcinoma, adenosquamous carcinoma, undifferentiated anaplastic carcinoma, undifferentiated carcinoma with osteoblast-like giant cells, and mixed ductal endocrine carcinoma. Here there is the serous cystadenoma and the mucinous adenocarcinoma, and the intraductal papillary mucinous carcinoma, and the acinar cell carcinoma, pancreatoblastoma, solid pseudopapillary carcinoma. These are the malignant tumors in the exocrine pancreatic tissue. Pancreatic adenocarcinoma, the ductal adenocarcinoma of the pancreas is the most common tumor. The other variants are adenosquamous carcinoma, undifferentiated carcinoma, colloid carcinoma, signet ring carcinoma, undifferentiated carcinoma with osteoblast-like giant cells, and hepatoid carcinoma. And the others, pancreatic adenocarcinoma, include acinar cell carcinoma, mucinous cystic carcinoma, intraductal papillary mucinous carcinoma, serous cystadencarcinoma. Ductal adenocarcinoma is the most common pancreatic neoplasm. It accounts for 90% of all pancreatic neoplasms. It can grow large enough to invade nerves, and this will lead to back pain. It also frequently spreads to the lymph nodes and the liver. And if it spreads to the liver, this is considered as an unresectable tumor. The adenosquamous carcinoma is a variant of ductal adenocarcinoma, is exceedingly rare. It accounts less than 1% of pancreatic cancer. It shows squamous differentiation and it is associated with poor prognosis. The colloid carcinoma, microscopically, there are small cell nests of cancer cells floating in pools of extracellular mucin. Many colloid carcinomas arise in association with intraductal papillary mucinous neoplasm, IPMN. The hepatoid carcinoma are exceedingly rare, and microscopically the cells look like the hepatocellular carcinoma. Acinar cell carcinoma is very rare. It accounts for 1 to 2% of exocrine pancreatic neoplasms. Metastases commonly occur to the regional lymph nodes and the liver. Distant spread may occur. Macroscopically, acinar cell carcinoma appears as a circumscribed mass and may be multinodular. Individual nodules are soft and vary from yellow to brown. There are areas of necrosis and cystic degeneration. Microscopically, the cytoplasm of the cells has a characteristic granular appearance. Pancreatic ductal adenocarcinoma, as we have said before, is the commonest pancreatic cancer. Pancreatic ductal adenocarcinoma and pancreatic cancer are terms that are interchangeably used. Here we can see the incidence and deaths in USA during the year of 2014. The 5-year survival of pancreatic carcinoma is poor. Cancer-related deaths in USA. In the year 2014, the top killers of cancer-related deaths were lung carcinoma, prostatic cancer, breast cancer, colorectal cancer, followed by the pancreas. In the year 2014, the top killers will be the lung cancer, pancreas, liver, breast, and colorectal cancer. Now, the pancreatic cancer is the third top killer from cancer-related deaths. This slide shows the median age of pancreatic cancer and percentage of new cases. Here we can see the peak of incidence of pancreatic cancer in 60s and 70s. But here cases has been reported between 35 and 45 years here, and even earlier than this year, but the percentage here is about 2%, and the peak is in 60s and 70s. Ductal adenocarcinoma pathology. Regarding the pathology of ductal adenocarcinoma, 80% of ductal adenocarcinoma are found in the head of the pancreas. Macroscopically, ductal adenocarcinoma is firm and poorly defined mass. The cut surface is yellow to white. Hemorrhage and necrosis are uncommon in ductal adenocarcinoma. Here we can see the molecular genetic progression from PanIN1 to invasive carcinoma, from PanIN1 to PanIN2 to PanIN3 to PanIN to invasive carcinoma. As we have said before, 80% of pancreatic cancer occur in the head of the pancreas. 70% of cases present with biliary obstruction due to lower bile duct obstruction. Pancreatic ductal adenocarcinoma is characterized by the desmoplastic reaction. Local invasion may occur in to the stomach, the duodenum, the colon, and the portal vein or superior mesenteric vessels, and distant spread may occur to the liver, the lung, and pancreatic intraepithelial neoplasia is considered as the precursor of pancreatic carcinoma. Pancreatic intraepithelial neoplasia are small microscopic precancerous lesions in the pancreas. They are called PanINs. They are too small to be detected by the current available imaging techniques. If left untreated, some PanINs will progress to be invasive ductal adenocarcinoma. Here, this is the flow chart. This flow chart shows the sequence of change from normal duct to cancer. Here in ductal adenocarcinoma, the normal duct will change into PanIN1A and PanIN1B and PanIN1-2 and PanIN3. If the tumor is cystic, also like intraductal papillary mucinous neoplasms or mucinous cystic neoplasm, there is dysplasia, and according to the degree of dysplasia, here the carcinoma, the dysplasia carcinoma sequence will occur. Here also PanIN1 dysplasia, and here PanIN2, and here PanIN3, and this will lead to invasive carcinoma. For also mucinous cystic neoplasm, also there is dysplasia, and there is a change from the adenoma to carcinoma. A sequence is also well documented to produce mucinous cystic adenocarcinoma. And here there is genetic progression. Here there is genetic progression. This is the normal cells here. This is the cells with PanIN1. There is here KRAS mutation in PanIN1, and also in here in PanIN2 there is a mutation of CN2A, and here in PanIN3 there is a TP53 mutation and SMAT4 mutation and BRCA2 mutation, and this is considered as a carcinoma in situ, and PanIN is considered as the precursor of ductal adenocarcinoma. So the progression from normal to intraepithelial neoplasia to invasive carcinoma is associated with architectural and cytological changes. As we have said before, this is the normal cells, and this is the change to PanIN 1 and PanIN 2 and PanIN 3 here. And PanIN 3 is considered as invasive carcinoma. Here there is a mutation of P53 and mutation of DPC4 and BRCA2. And here in PanIN 2 there is a mutation of P16, and in PanIN 1 and PanIN 1 here there is KRAS mutation. And so there is architectural and cytological changes in the PanIN to produce invasive carcinoma. These histological pictures shows the change from normal cells to PanIN. Here we can see the normal cells here. This is PanIN 1A, and here cells with PanIN 1B, and here there is change into PanIN 2, and here there is change into PanIN 3. We can see the change from the normal cells here to PanIN 3, and here the PanIN 3 is considered as in situ carcinoma and is the precursor of pancreatic ductal adenocarcinoma. The risk factors of pancreatic cancer include the family history of pancreatic cancer, smoking, alcohol, obesity, diabetes mellitus, chronic pancreatitis, and familial cancer syndromes. The clinical manifestations of pancreatic cancer. The symptoms of pancreatic cancer, the patient may present with athenia, weight loss, anorexia, abdominal pain, mainly in the epigastric region. The patient may present with jaundice, with dark urine and a clay stool. Also, the patient may be nauseating. If pain occurs, it would be mostly to the referring to the back, and this is considered as an advanced case. Also, the patient may develop a cancer cachexia, and really some patients develop thrombophlebitis in 3% of cases. Signs of pancreatic cancer. The patient may present with jaundice, with itching marks, and also Courvoisier sign may be detected during palpation of the abdomen, as the gallbladder is distended at the right costal margin. Unfortunately, the signs of pancreatic cancer in many cases develop late with advanced stages of the disease. Epigastric mass is a sign, very late sign, and also cancer cachexia and ascites are very late signs of pancreatic cancer. And we have to detect the patient before development of late signs of cancer. This flow chart shows the diagnostic workup of pancreatic cancer after examination of the patient and laboratory investigation. Diagnosis and staging of pancreatic cancer is confirmed by pancreatic protocol CT or pancreatic protocol MRI. In some cases, we have to do endoscopic ultrasound with EUS guided biopsies, and also if EUS is not available, CT guided biopsies may be needed to confirm the diagnosis. ERCP is used for therapeutic purposes for drainage of the biliary tree due to high bilirubin level and marked jaundice in patients with pancreatic cancer. These are the imaging modalities for diagnosis of pancreatic cancer. Here, this is the abdominal ultrasonography that is routinely used in most of cases. The CT and the MRI are very, very valuable for diagnosis and staging of pancreatic cancer. We have to use what's called the pancreatic protocol CT or pancreatic protocol MRI for proper diagnosis and staging of pancreatic cancer, and to determine the resectability status of the tumor. EUS is available for also diagnosis and histologic acquisition of fine needle aspiration for histopathological examination of the tumor. The PET-CT is useful to determine the activity of the tumor and determine whether there is mets. ERCP is mainly used for therapeutic purposes in pancreatic cancer to achieve drainage with ERCP with stenting. Serum CA99 as a tumor marker in pancreatic cancer is routinely used. It is a glycolipid tumor marker. Its level correlate with the size of the tumor and the stage of the tumor, but for large tumor and late stages. So it is used only for monitoring the disease progression and for prognosis. Staging and prognosis of pancreatic cancer. In stage 1A, the tumor is less than 2 cm in diameter and is confined to the pancreas. In stage 1B, the tumor is more than 2 cm but is still confined to the pancreas. In stage 2A, the tumor extends beyond the pancreas, but there is no involvement of the spuromesenteric vessels or the celiac axis. In stage 3 is the tumor involves the celiac axis or the spuromesenteric artery. If the tumor is in the head, it may encase the spuromesenteric artery, and if the tumor in the body, it may encase the celiac axis by more than 180 degrees, and this is considered as a borderline or locally advanced tumor. Stage 4 is considered as distant metastasizing tumor. The staging correlates with the 5-year survival and the median survival here. And pancreatic cancer is known as a tumor with a very bad prognosis. Pancreatic cancer resectability. Before embarking on pancreatic surgery, tumor resectability is best determined by using a pancreatic protocol CT or pancreatic protocol MRI for better assessment of resectability. The tumor may be resectable or locally advanced or borderline, and a resectable tumor there is no extension to the celiac axis or the spuromesenteric artery with patent spuromesenteric vein portal vein confluence. In locally advanced disease, there is encasement of the spuromesenteric artery. If the tumor is in the head of the pancreas, there is encasement of the spuromesenteric artery by more than 180 degrees, and if the tumor is in the pancreatic body, there is encasement of the celiac axis by more than 180 degrees. For borderline tumors, there is arterial encasement by nearly 180 or 180 degree, whether the tumor in the head or in the body of the pancreas. If the tumor in the head of the pancreas, borderline tumors, there is encasement of the spuromesenteric artery by nearly 180 degree or 180 degree, and if the tumor in the body of the pancreas, there is encasement of the celiac axis by nearly 180 degree or 180 degree. These are the National Comprehensive Cancer Network guidelines, NCCN guidelines, in terms of pancreatic protocol CT parameters and principles, the type of scan, the thickness of the sections, and the contrast agents and the intravenous contrast, all of these to achieve a high quality pancreatic protocol CT for proper diagnosis and the staging of pancreatic cancer to determine resectability. These illustrations show the radiologic descriptions and radiologic classification of portal vein spuromesenteric vein involvement to determine resectability. In type 1 there is normal vein, in type 2 there is a smooth unilateral shift, in type 3 there is unilateral narrowing, in type 4 there is bilateral narrowing, and in type 5 there is bilateral narrowing with collateral veins. These illustrations show the pancreatic resectability of a pancreatic head mass, the status of resectability, Here, this is the mass in the pancreatic head. This is the duodenum. This is the superior mesenteric vein, and this is the superior mesenteric artery. Here we can see a clear plane, fat plane between the tumor and the superior mesenteric artery. So this is considered as a resectable tumor. For borderline tumor, there is encasement here. This is the tumor. There is encasement of the superior mesenteric artery by about 180 degree or just less than 180 degree. This is the superior mesenteric vein here. This is the superior mesenteric artery. There is encasement of the superior mesenteric artery by nearly 180 degree here. This is considered as borderline resectable tumor. In locally advanced tumor, here there is encasement of the superior mesenteric artery by more than 180 degree. And this is considered as locally advanced tumor and unresectable tumor. This is a CT image showing resectable pancreatic tumor in the head of the pancreas. Here is the tumor here in the head of the pancreas, and this is the superior mesenteric artery, and this is the superior mesenteric vein. Here we can see a clear fat plane between the tumor and the superior mesenteric artery. This is considered as a resectable tumor. This CT image shows a borderline resectable tumor. Here we can see this is the tumor. A stent, a plastic stent has been placed here in the bile duct here by ERCP. This is the stent. This is the tumor. There is encasement of the superior mesenteric artery by nearly 180 degree. So this tumor is considered as a borderline resectable tumor. In this CT image, there is a locally advanced tumor. As seen here, this is the tumor. This is the superior mesenteric artery. There is encasement of the superior mesenteric artery by more than 180 degree. And this tumor is considered as a locally advanced tumor. This is a locally advanced tumor with encasement of the superior mesenteric artery by more than 180, and there is also encasement of the celiac axis by more than 180 degree. The general principles of treatment of pancreatic cancer. Pancreatic cancer treatment is a multidisciplinary. Surgery is the mainstay treatment for resectable disease, followed by adjuvant therapy. For borderline and locally advanced disease, neoadjuvant chemotherapy is recommended by the international guidelines to downstage the tumor to be resectable. The management of metastatic disease is by chemotherapy, gemcitabine-based combination treatment, or according to clinical trials. Surgery for pancreatic cancer. Surgery is the mainstay treatment of resectable pancreatic cancer. The surgical procedure differ according to the site of the tumor. If the tumor is in the head, pancreatic duodenectomy is done, which is called a Whipple procedure. If the tumor is in the body of the or tail of the pancreas, distal pancreatectomy is done. Rarely, subtotal distal pancreatectomy or total pancreatectomy is done. There are technical considerations for each procedure, and the role of laparoscopy is well established, whether for diagnosis or for therapeutic purposes. In distal pancreatectomy, it is used for selected cases of distal pancreatectomy, and in Whipple procedure, it is very, very limited in very selected cases. The post-operative care for patients with pancreatic cancer is very, very important, aiming to decrease the morbidity and mortality. The morbidity has decreased, and it is about 20 to 30% patients, and the mortality has decreased, and it is now below 5%. Surgical procedures for pancreatic cancer. The commonly used procedures are pancreatic duodenectomy and distal pancreatectomy. Pancreatic duodenectomy is done for tumors in the head of the pancreas. Here an illustration showing the pancreatic duodenectomy for a tumor in the head of the pancreas. Here we see the parts that will be resected here. It includes the duodenum, the head of the pancreas till the neck of the pancreas, the first part of the jejunum, the lower end of the bile duct, and the gallbladder. Here, in this illustration, it is a pylorus preserving pancreatic duodenectomy. If the pylorus is not preserved, it is the classic pancreatic duodenectomy. Reconstruction is then done by pancreaticojejunostomy and hepaticojejunostomy and duodenojejunostomy or gastrojejunostomy. Here there is distal pancreatectomy in this illustration, showing the part of the to be resected, the body and the tail of the pancreas, together with the spleen and the lymph nodes here. We have to secure the pancreatic duct to avoid biliary leak post-operatively. In this picture, an picture from an operation of distal pancreatectomy. Here we can see the spleen, the tail of the pancreas. This is the body of the pancreas. Here the tumor. In this operation, it was a near total distal pancreatectomy. This tape is around the neck of the pancreas, and near total distal pancreatectomy with splenectomy was done in this case. This illustration shows the intraoperative assessment of resectability. Here the duodenum has been mobilized here, what's called the cockerization of the duodenum here, and dissection of the head of the pancreas is done posteriorly here. This is the aorta, and this is the IVC, and this is the spuromesenteric artery, and this is the spuromesenteric vein. This is called cockerization of the duodenum, and also here for assessment of resectability, the neck of the pancreas has to be dissected from the spuromesenteric vein for assessment of resectability before embarking on resection during Whipple procedure. This illustration shows the resection margins and the specimen during pancreatic duodenectomy. This is the neck resection margin, and this is the spuromesenteric artery margin, and this is the resected specimen together with the mass here. This is the spuromesenteric artery margin here. This is the spuromesenteric artery, and this is the spuromesenteric vein. This is the resection margin at the neck. This is an operative picture during pancreatic duodenectomy. Resection has been completed. Here the spuromesenteric vein is clear here, and this is the spuromesenteric vein splenic vein confluence, and this is the portal vein. The spuromesenteric artery is deep here to the left and posterior to the spuromesenteric vein. This is the pancreatic stump, the remnant pancreatic stump, ready for anastomosis. This is the resected bile duct here, the stump of the bile duct here for anastomosis. This is an operative picture during pancreatic duodenectomy, starting reconstruction with pancreaticojejunostomy. This is the pancreatic stump here. This is the pancreatic duct here. This is the loop of the jejunum, ready for reconstruction. This is the stump of the jejunal loop. This is the loop for reconstruction. The reconstruction started with pancreaticojejunostomy end-to-side anastomosis. We have to follow the National Comprehensive Network guidelines as regard the resection margins, and the resection margins should be free. Here, the important resection margins include the neck resection margin, the pancreatic neck resection margin, the posterior, the portal vein groove margin, and the spuromesenteric artery margin, and the posterior margin. And we have to follow the NCCN guidelines regarding the resection margins. The resection margins and the resection status. Our goal during pancreatic duodenectomy or operation for pancreatic cancer is to achieve RO resection. RO resection means complete gross resection and the microscopic margin is negative. R1 means that there is complete gross resection, but there is a positive microscopic margin. In R2 resection, there is incomplete gross resection with a positive margin. Our goal is to achieve RO resection. This chart shows the 5-year survival by stage for patients with pancreatic adenocarcinoma treated by pancreatectomy alone. It's clear that the prognosis is poor, so pancreatic carcinoma should be treated by a multidisciplinary team. Treatment of borderline resectable pancreatic cancer. Surgery first approach or neoadjuvant therapy. This flowchart shows the National Comprehensive Cancer Network guidelines for treatment of borderline pancreatic cancer. A biopsy is to be taken, preferably by EUS, and self-expandable metal stent, short self-expandable metal stent is inserted if there is biliary obstruction, and a baseline CA19-9 is done. If the biopsy is positive for pancreatic adenocarcinoma, neoadjuvant therapy is initiated, and then after a neoadjuvant therapy, a pancreatic protocol CT or MRI is done, and also chest CT, and post-treatment CA19-9 is done. If the tumor is downstaged and resectable, surgical resection is done. If the tumor is unresectable, the patient is considered as a case of locally advanced or metastatic disease and should be treated in this manner. If the tumor is resectable after resection, the patient should receive adjuvant treatment. The approach of management of borderline resectable pancreatic cancer. Here we can see after staging of the tumor, and if the tumor has been classified as a borderline tumor, chemotherapy is initiated, followed by restaging, followed by chemoradiotherapy. Here some dropout of cases will be seen, and after chemoradiotherapy, a break of about 6 weeks, and followed by restaging by pancreatic protocol CT or MRI. If there is downstaging of the tumor, the patient will be ready for surgery. And here, during restaging, some dropout of cases is seen. Neoadjuvant treatment. The potential advantages of neoadjuvant therapy include there is better oxygenated tissue for neoadjuvant therapy, also tumor downstaging, and enhancement of the chance of complete resection, RO resection. Also, the outcome of R1 is much better than R2 resection, and the neoadjuvant therapy will select those with favorable biology to undergo surgery later on after downstaging, and treatment of radiologically occult M1 disease. There are some contrary opinions against neoadjuvant treatment. These include the biology of pancreatic cancer precludes any therapeutic effect due to the desmoplastic reaction in the stroma and cell paucity. The local regional metastatic disease can be staged preoperatively in most of cases. Early declaration of metastatic disease is rare, as it is detected only in 10% of cases. Pancreatic cancer patients cannot be cured without the primary therapy or surgical resection. Tumor markers and neoadjuvant therapy. What happens with CA19-9 with neoadjuvant therapy of borderline tumor? This pie chart shows the correlation of CA19-9 and the resection status after neoadjuvant therapy. In this sector, the level of CA19-9 has decreased and a resection of the tumor was done. In this sector, the level of CA19-9 has decreased, but the tumor was not resected. And in this sector, there is increase in the level of CA19-9 and the tumor was not resected. And in this small sector, there is increase in the level of CA19-9 and the tumor was resected. Key messages for treatment of borderline resectable pancreatic cancer. The management of borderline resectable pancreatic cancer is still evolving. Pancreatic protocol CT, MRI, EUS are essential to determine the resectability status. The treatment involves induction chemotherapy followed by chemoradiation before surgery. The ability to obtain negative margins during resection is of utmost importance for improving the outcome. Palliative therapy for pancreatic cancer. Palliation of pain for pancreatic cancer, there is the celiac plexus neurolysis, which is commonly used either by the anterior transgastric approach or the posterior approach. The anterior transgastric approach is by CT or EUS guided. The posterior approach is percutaneous by CT or fluoroscopy. There is also the thoracoscopic splenectomy. For palliation of biliary obstruction, ERCP with stenting is more commonly used than the PTC drainage. Here we can see the ERCP, the fluoroscopic view of ERCP here, and there is a long structure suggestive of pancreatic head cancer. Stenting here, endoscopic view with the stenting. This is a plastic stent. This is an endoscopic view with metallic stenting. For palliation of gastric outlet obstruction, endoscopic stenting and laparoscopic gastrogenostomy are more commonly used than the open gastrogenostomy. Endoscopic stenting, as a minimally invasive technique, it improves the dietary performance in more than 80% of cases, and there is a short time to oral intake with a short hospital stay. Key messages for treatment of pancreatic cancer. Local tumor resectability is best determined by high-quality pancreatic protocol CT or MRI. Resectable tumors are treated with upfront surgery. Borderline tumors are best treated according to the international guidelines with upfront chemotherapy, chemoradiation followed by surgery. Locally advanced tumors are treated by chemoradiation, endoscopic stenting if needed, and then reassessed for surgery. Metastatic disease is treated by palliative chemotherapy with palliative treatment of jaundice and gastric outlet obstruction. Thank you very much for your attention.